So this was a 28-year-old female. She is a nurse by profession who presented to us with complaints of sudden onset loss of vision, diminution of vision in her left eye after she attended a dance party in the night 10 days ago. She was extremely apprehensive when she came to us and full of anxiety. So on evaluation, we realized she had no other systemic or blood related problems. Her best corrected visual acuity was 6/6 in right eye and 6/18, that is around 20/63 in the left eye. So our fundus evaluation and OCT showed that there was a prefoveal hemorrhage. So you can see the blood was covering just the center of the eye. It was right in the foveal pit. The diagnosis for us, because she had no other systemic problems like hypertension, diabetes, and no other hematological disorders which could explain the sudden bleed, and because she had been partying the night before, she had some alcohol also, and there was some episodes where she had a vomiting because she probably drank a bit too much. The diagnosis we made was that she was having what we call Valsalva retinopathy. What is Valsalva retinopathy? Now, Valsalva retinopathy is a sudden onset bleeding in the center of the eye, as you can see here in this image, which occurs due to something called a Valsalva maneuver, where there is a forceful expulsion of air with a closed airway. This maneuver can cause sudden increase in venous pressure within the eye, causing rupture of the superficial retinal capillaries, especially the small capillaries at the center of the retina, which is also called macula. With the diagnosis, what were the options that I had? So the first and obvious option that we always have in such cases of Valsalva maneuver, and also we had in this patient, was not to do anything at all. Valsalva retinopathy, we know, can resolve with time on its own, but our patient was extremely anxious. She was unable to carry out her work, and she was having difficulty because she was not getting any medical leave also. She was very stressed out. So we decided that we had to do something for her. Now, in Valsalva maneuver, a very popular way of treating the patient non-invasively is by using YAG laser membranotomy, where basically what we do is, now this blood is actually under the internal limiting layer, internal limiting membrane, that is a skin of the retina or the innermost layer of the retina. So in YAG laser membranotomy, basically we make a puncture using the YAG laser into the ILM and sort of drain the blood. But in this case, since the blood was right in front of the fovea and it was a very small amount of blood, trying to puncture the ILM here carried a lot of risk, and it was very likely that we may end up injuring the fovea, the foveal retina, either creating a laser-induced macular hole or causing a foveal burn, which would cause her to permanently lose vision, and of course that is not acceptable. Now, what about injections? Can we try anti-VEGF injections in these cases? So the answer is no, because this is blood which is trapped under the sort of ILM. Inject anti-VEGF, this is not going to make any difference, because the momentary changes in the capillaries which led to this bleeding, that part is already done. It's in the past. It happened when the Valsalva maneuver took place. Now by injecting, you are not going to change the nature of the blood vessel or the vascular milieu. Rather, those injections can lead to organization of the blood here, and since this blood is trapped under the ILM, over a period of time this organized blood can cause pressure on the fovea and even some amount of irreversible vision loss. So we decided that we'll go ahead with a surgery. Surgeries for Valsalva maneuver is, as I said, not the most popular step. YAG laser hyaloidotomy is, or YAG laser membranotomy is, but that is reserved for large bleedings. Here we felt that since the patient was anxious and we couldn't wait, the only best way to give back her vision would be to remove this blood by releasing it from under the internal limiting membrane. So what was our plan? The plan was to do a micro-incisional vitreous surgery, and we prefer to do the surgeries at our center with 23 gauge. I am not convinced that 23, 25 or 27 gauge really makes a huge difference in patient outcome. And in our setup where cost of treatment and all that matters a lot, 23 gauge because of his sturdiness makes up for our requirements. And we have been using the Oatley's OS4 platform at our center since January 2024. So the steps that we planned in this surgery were: first we'll do a vitrectomy. Next, we will peel the posterior hyaloid so that we could reach up to the internal limiting membrane. Then we'll peel the internal limiting membrane, which was covering the blood. And hopefully, once we had removed all these barriers, the vitreous jelly, the posterior hyaloid, and the internal limiting membrane, it would be easy for us to remove the blood from the front of the fovea. So this was our plan. Let's see how it went. So as you can see, we started the surgery with 3 trocar cannulas. So this was step 1, doing a vitrectomy. Once the vitrectomy was completed, we stained the posterior hyaloid with triamcinolone acetonide so that we can see the posterior hyaloid. And then we tried to induce a posterior vitreous detachment with the cutter in suction mode. As expected, in a young patient, it is very difficult to induce PVD because the vitreous is physiologically well attached to the retina at this stage. Therefore, even though we tried and tried, we simply couldn't induce the posterior vitreous detachment. So we were stuck at step 2. Now what should I do then? So one option that I had was to keep trying, but it is always risky. If you keep on forcefully trying to induce PVD, sometimes you may inadvertently end up inducing iatrogenic retinal tears and breaks. Now this is a young patient, and honestly speaking, her eye is absolutely perfect except for that small amount of blood in front of her fovea. So if I did induce a tear during attempts to induce PVD, and then the patient ended up with a retinal detachment, it would be a big mess because we'll be actually causing harm to the patient. So I realized that it will be not right of me to keep on trying to induce PVD. Rather, I thought, let me move on to the next step. And the next step, by that I mean staining the ILM and trying to peel the ILM. Why so? So if you see the OCT image of a normal retina, so the star we see here actually indicates is the posterior hyaloid. Now if we see the posterior hyaloid, we know is attached to the retina at around the fovea, but the uppermost layer or the innermost layer of the retina is the internal limiting membrane. So if we can somehow remove this internal limiting membrane, it's like you are peeling off the skin of the retina, and all the vitreous which is attached to the skin will naturally get peeled off simultaneously. So that was the plan with which we decided that we'll not try to force this vitreous away from the retina, but rather let's try to stain the internal limiting membrane and peel it, and hopefully we can then remove both these membranes, the internal limiting membrane and the vitreous, simultaneously. So that's what we did. We stained the internal limiting membrane with a brilliant blue dye, and then by changing the color of the illumination to more yellow and less blue as we do in OS4, we went ahead and started peeling the ILM. Now you can still see the triamcinolone particles here which are staining the vitreous. Now as I kept peeling the internal limiting membrane, you can see now clearly that the vitreous is also coming off as a membrane. So you can see this triamcinolone stained membrane is actually the vitreous. The bluish membrane, of course, is the internal limiting membrane. So once the ILM had been moved with the help of the cutter, now I could easily separate the vitreous from the retina. So you can just keep seeing here, this is the vitreous which is now coming off. So now step 2 and step 3 both have been achieved. So now we are left finally with the step 4, that is removing the blood. I tried to gently aspirate the blood away from the fovea, but it was not coming off. So instead I used a flute needle to simply dislodge the blood away from the fovea. Now this has to be done very gently, because if I forcefully try to do that, I may end up creating a macular hole. So with multiple small gentle throws of air, I could dislodge most of the blood from the prefoveal space. So this was probably the capillary which actually ruptured and caused the bleeding. So a month later, the patient came back and she was very happy. This was her pre-operative picture, and this the post-operative picture. You can see clearly all the blood has now gone away from the fovea, and her vision has also recovered very well. 6/9, that is around 20/32, which I expect to improve further in 2 to 3 months. The OCT through the fovea confirmed the same. So there was no retinal damage. You can clearly see that, and you can see all this prefoveal blood has also gone. So this was a patient, a young patient, female, who complained of sudden loss of vision, and we diagnosed her to be a case of Valsalva retinopathy. But unlike other cases of Valsalva retinopathy, this here the blood was very limited and it was just sitting on front of the fovea. So it was causing a lot of vision problem to the patient, but since the amount of the blood was very less, so we couldn't try the non-invasive option of doing a EAG hyalotomy. Instead, we had to consider doing a surgical removal. And during the surgery, one interesting thing we learned was that if you are stuck and trying to induce PVD in a case because the patient is very young or the vitreous is very strongly adhered to the retina, an alternative option is you peel the ILM by staining it, and then once you remove the skin of the retina, the hyaloid also tends to come off along with the ILM. Thank you for watching the video till the end. Hope you found the case interesting. Would you have managed a similar case in the same manner that I did? Do let me know through your comments. Thanks for watching.